Understanding Childhood Trauma, presentation by Anna Duran, Joseph Hart, and Paul Siegel. In working with individuals with a history of trauma, professionals in the field of mental health often turn to adverse childhood experiences, also referred to as ACEs, scores to determine the risk factors associated with each individual in their care. According to research, nearly two-thirds of adults report experiencing at least one ACE during their childhood. It's notable that not everyone that has experienced an ACE during their childhood endorses the experience of trauma or traumatization. However, individuals who have experienced one or more of these adverse events are significantly more likely to develop a host of disorders, illnesses, and symptoms associated with unresolved trauma. Specifically, higher ACE scores are associated with symptoms and disorders such as depression, anxiety, other mental health disorders, substance use disorders, suicidal ideation and attempts, as well as attempts for self harm, and other chronic health conditions such as various cancers, cardiovascular disease, diabetes, and ultimately shortened lifespans. This is relevant to the social worker and other mental health professionals as it highlights the need for consideration of the multidimensional person in their care. Assessments used in models like the biopsychosocial consider all facets and dimensions of the person that they are working with and consider things like mental health and substance use disorders as symptoms and byproducts of an underlying cause and part of the whole person as opposed to simply defining the person by their illness or disorders. To better understand trauma, it's necessary to define what trauma is and how traumatization occurs. Trauma is a response to a distressing or disturbing event that overwhelms an individual's ability to cope, not just their mental emotional coping capacity, but also their physical coping capacity. Traumatization occurs as a result of an individual's experience or perception of an event, as opposed to the event itself. This means that trauma and traumatization can be a very subjective and relative experience to individuals. Furthermore, forms of trauma are vast and widely varied. Some examples include abuse, neglect, various forms of violence, natural disasters, and the loss of loved ones. Trauma and traumatization can occur from a variety of different environments, situations, and outliers. Trauma can be both physical, mental, and psychological, and emotional. Furthermore, traumatization can occur from certain situations and external pressures, even when an individual grows up in a loving household. Further expanding on this, the question, what are ACEs, is answered both in the ACEs form and in the slide below. Notably, there are multiple categories addressed in the ACEs test, including forms of abuse, household challenges, and forms of neglect. Notably, to my last point, even in a loving environment, household challenges can create traumatization. In a loving environment where both parents are present, but resources are scarce due to chronic poverty or generational poverty, an individual may develop trauma from chronic stress, from a lack of resources, both financial and the conduits through which means are gained by financial substantiation. This includes lack of food, transportation, and housing. The CDC Kaiser Permanente ACEs study is a historic landmark in public health investigation that linked childhood trauma to adult health and well-being. This is especially relevant considering that the consequences of childhood trauma may present immediately, but also may wait until later in life to present themselves in those individuals. Things like chronic disease and early mortality are both factors that may present later in life due to the persistence of chronic stress relating to adverse childhood experiences. On this slide, we see two common forms of testing or screening for adverse childhood events, both the CDC ACE questionnaire as well as the PEARLS screener. While neither is necessarily superior to the other, they both tend to measure the risk factors associated with each individual's upbringing and environmental life during childhood. The ACE questionnaire consists of 10 questions surrounding both relational and environmental factors in a child's life. Answering yes or no or not sure provides a score which indicates a child's risk factors as an adult. Trauma is indiscriminate. Much like other risk factors such as cancer and chronic disease, illness born of adverse childhood experiences does not discriminate based on sex, gender, religion, or financial capacity. However, there are some populations that are at higher risk for adverse childhood experiences, including children experiencing chronic poverty, children in the foster and welfare systems, historically marginalized communities, as well as individuals that grow up in homes of addicts and an environment of abuse. Trauma-related disorders are varied, and below is featured just a few examples of the most commonly identified trauma-related disorders. The DSM-5 has a classification of stress and trauma-related disorders that is extensive. What we see most commonly are ASD, or acute stress disorder, and post-traumatic stress disorder, also known as PTSD. Typically, the symptoms of both of these disorders are similar. However, the criteria to meet the disorder is varied slightly. Notably, in ASD, this is a short-term consequence of traumatization, typically lasting less than a month before resolution occurs. Additionally, the criteria necessary to meet for diagnosis is at a lower threshold than the one for PTSD. For PTSD, while symptoms may present immediately, they may also present at a later date, much like we talked about with the consequences of ACEs. Additionally, the persistence of symptomology consists of longer than 1 month, potentially throughout the lifetime. Furthermore, PTSD diagnosis requires a variety of criteria to be filled across multiple domains. Though not formally recognized as an individual diagnosis by the DSM-5, other standard of care books and manuals, as well as other professional organizations, recognize the existence of what's called complex post-traumatic stress disorder, or CPTSD. Again, the symptomology associated with this diagnosis is very similar to both ASD and PTSD. However, individuals with CPTSD do experience more complex symptoms, including challenges with emotional regulation, interpersonal relationships, and identity. This not only exacerbates the level of treatment or the ability to treat this disorder, but it also makes the treatment much longer. CPTSD is often associated with chronic exposure to trauma or recurrent traumatization. For this, we think of relationships that have been persistent throughout a lifetime or for an extended period of time that would be deemed abusive or unhealthy. Furthermore, as it relates to ACEs, children who grew up in unsafe or unstable environments are more likely to develop complex PTSD. Social workers in various roles and capacities are required to assess trauma and, in some instances, ACEs in a variety of fields and settings. Notably, for individuals at the bachelor's level of social work, there are factors to assess and determine level of care that are within their scope. For the clinical social worker, there are also evidence-based treatment modalities to consider and higher levels of treatment and care falling within their purview. Settings where social workers practice are all inclusive in dealing with individuals in trauma. Not one is exempt from potentially encountering individuals who have experienced significant ACEs and therefore consequences of those experiences resulting in traumatization. Schools, child welfare systems, mental health clinics, and substance use treatment programs all fall within the social worker settings where they will encounter individuals who've had these experiences. It's necessary for the social worker to be duly informed in how to care for individuals who've experienced trauma. We refer to this as trauma-informed care. Principles of trauma-informed care include safety, trustworthiness and transparency, support, collaboration, empowerment, as well as utilizing cultural humility. As with everything in the field of mental health work, and social work, prevention is paramount and key to the prevention of the consequences of traumatization in future generations. Prevention strategies often used by social workers in their various settings include parent education programs, school-based mental health programs, early childhood interventions, community support programs, and strengthening protective factors and resilience. Unfortunately, prevention isn't a universal success, and unfortunately as well, that means that there are still children experiencing these adverse experiences throughout their childhood that will experience consequences such as the ones noted before. Because prevention isn't a universal success at this time, there are a host of modalities and considerations in the treatment of individuals who have experienced ACEs and traumatization. One such modality is the use of trauma-focused CBT, cognitive behavioral therapy. CBT with a trauma focus is an evidence-based treatment designed for individuals who have experienced trauma and has been shown to reduce symptoms of PTSD, anxiety, depression, and other behavioral concerns. Key components to this modality include psychoeducation, learning coping and relaxation skills, cognitive processing, trauma narrative development, and caregiver involvement. As with any profession and treatment modalities within that profession, the use of trauma-focused CBT requires specific training by a qualified individual. The video seen here uses a polyvagal perspective of trauma and the nervous system and how trauma changes the way that an individual's nervous system operates in response to external stimulus. Utilizing the polyvagal perspective and drawing on science research on the autonomic nervous system in different levels of arousal, including sympathetic and dorsal. The video expands on the idea of states of safety, danger, and immobilization. Furthermore, it expands on the consequences of ACEs and how to heal a nervous system affected by chronic stress and trauma. Furthermore, the video expands on the need to address the underlying cause of symptoms presenting in individuals with a history of trauma. This includes not only dealing with the current symptoms as they present through the utilization of grounding and coping skills, such as co-regulation, EFT tapping, and other skills provided in modalities like DBT and CBT, but also addressing the underlying condition and experience of the trauma that occurred during childhood. By helping individuals associate properly the difference between dangerous settings, environments, and interactions and ones that are safe, the consequences experienced from childhood traumatization can be lessened, and possibly an individual may be able to resolve those symptoms altogether. That being said, healing from trauma is about healing, not curing. The need for tools and skills are expansive for each individual and just as varied. Again, a host of modalities and different forms of treatment exist within the realm of healing from trauma. Here we see a few modalities that alter in their approach. Brain spotting and EMDR, similar in their delivery, focus on the historical trauma itself and ask individuals to look at an experience in order to help resolve a person's sensitivity to it. Meanwhile, seeking safety, which is often found in substance use facilities that serve dual diagnoses clients, focus on a present moment approach, dealing with the here and now, which absolves the client or patient from having to directly reflect on the traumatizing experience. This reduces the risk of re traumatization as well as an overwhelming sense of activation that may not be appropriate for various levels of care. Thanks to the work of mental health professionals as well as medical professionals, the stigmas associated with various forms of mental illness as well as substance use disorder has been lessened over the last several years. However, some stigmas do remain. While the overwhelming majority of society feels compassion and sympathy for individuals, most especially children, who've experienced trauma, they oftentimes continue to rely on a moral model of understanding for the adults that those children grow into. As it relates to various adult onset disorders, such as substance use, which oftentimes presents in adolescence and early adulthood, much of society, as well as governing agencies, continue to demonize these individuals whose afflictions are a byproduct as a means of coping from the experiences of their traumas. Furthermore, the isolation and alienation of individuals experiencing mental health disorders that ultimately lead to an inability to function in society and who experienced chronic homelessness, lack of employment, and the need for public resources are also continuing a stigmatization that ignores the history of trauma that related to the consequences of an adult unable to care for themselves. The references provided here in our work are but a few of the mountain of papers by professionals and organizations that have done remarkable research and studies on the effects of early childhood trauma, ACEs, adult trauma, and the consequences associated with traumatization for the field of mental health and medical purposes. As social workers, it is our duty to champion not only for the children who are at risk of developing traumatization, but also for the adults whose developmental capacity and progress was delayed by the onset of symptoms associated with the traumas they've experienced. It is our responsibility not to forget that every adult, every family that we encounter came from somewhere, and the use of multidimensional modalities and assessments is necessary to consider all factors that led our clients and patients to walk through our doors asking for help. As social workers and caregivers, it's our responsibility to see the victim and not the villain.